So thank you all for coming back. We have 2 sessions left today. I do want to remind everybody that we have sessions lined up tomorrow starting at 10 a.m. Eastern Time. Again, a number of fabulous speakers and panels. Really looking forward to carrying this conversation over the next couple of hours and then into tomorrow. So for those that I don't know and those online, my name is Sean Martin. I am the Executive Vice President and CEO of the American Academy of Family Physicians, and we're proud to be a partner and co-founder of Primary Care for America, along with many organizations that are represented here today and participating online. The AAFP represents just over 127,000 family physicians practicing in about 95% of U.S. counties around the country, many of them practicing comprehensive primary care across the life span of their patients and communities. Again, we're very honored to be here with our founding organizations and co-hosting this important conversation around the future of primary care and the value of primary care. So my next responsibility is to introduce Dr. Kara Odom Walker, who is a Executive Vice President and Chief Population Health Officer at Nemours. And she is going to, I told you I would mess that up. And Dr. Walker is a family physician, is going to be having an important conversation around how primary care can reduce health disparities and create a more equitable healthcare system. Dr. Walker, thank you so much.
And I'm looking forward to today's conversation. Obviously, we know there are many challenges in healthcare today. In my role at Nemours Children's Health, we see 1.9 million patient encounters annually and have more than 80 locations across 5 states. And we see these challenges every day around trying to manage towards better health, create the healthiest generation of children. That is our goal, and I try to think about that every day. But we know in the context of healthcare today, it is truly a challenge and opportunity for primary care. We know that the US outspends all other industrial nations in healthcare, and yet we don't necessarily produce better health or fewer inequities. We know we also spend less in primary care, and one of my prior roles as Secretary of Health and Social Services in the great state of Delaware, we really tried to figure out how to measure and invest in primary care. And I would say as a healthcare provider, as a family physician, and trying to figure out really how do we bend that cost curve, it was challenging from a policy perspective, but also one that brought many wonderful conversations about how do we redesign the workforce to address these needs? How do we refocus the few dollars we have at the federal and state level to make investments? But we know that, a baby born in the US, unfortunately, can expect to live to about 78, but just going across the border to Canada, that same child will live longer. It is quite unfortunate. Among industrialized nations, we rank 28th in infant mortality among 30 countries. And that gap is often drawn just by looking at Black-white differences in infant mortality. It is something we think about at Nemours, and it's something that is incredibly hard to move and change. These health disparities are often influenced by our population health differences, by race and ethnicity. Yet my primary care teams are trying to do this work one by one with maybe some conversation around what are the social factors, what are the social needs that our patients see. We are administering a social needs screener at our visits, and what we're finding is that our parents are asking for help to navigate some of the most difficult intersections in health today, and that's housing, broadband access, differences in education, and yet our primary care docs would love to connect to services, and sometimes we just can't meet that need. It is truly what I see as the opportunity to create intersections and investments, but we also know that these differences in health equity have been driven by long-standing challenges in investing in education, in housing, in income, and other long-standing root causes. We're trying to overcome and go up that mountain with fewer and fewer resources. We also know that primary care is situated at the perfect intersection of neighborhoods and communities. And when we talk about social needs, we should look at zip code as one of those other risk factors. It is just as important as looking at whether there's a smoker in the home or we're screening for other health factors. It is a more important predictor of lifespan. And I know tomorrow's conversation will focus on maternal health, and then we'll talk about infant mortality and asthma and some of those featured areas that we talked about at the last session. I would say that overall, I am optimistic. And if I think about the levers that primary care has to think about bringing in families to addressing these needs, we can start somewhere. I mean, if you think about it, who knows the patient history best? Who knows the family circumstances? Who has the conversations around housing and community safety and whether they are food insecure? I know our parents that we interact with in our clinics are often asking questions about navigating to those resources, and it is challenging. But that touch point and that trust starts with primary care. It is that interaction that brings preventive care into the conversation. And although it is harder and harder to invest in prevention, we also know it can turn into improved health outcomes. It is primary care that through risk-based arrangements and value-based orientation, we are starting to put more of that responsibility and accountability into our primary care setting. Who is it who's going to be responsible for reducing hospitalizations or avoiding unnecessary emergency department use? It is our teams in primary care settings. It is my community health worker who's going to go door to door and try to find out why one of our patients may land in the emergency department as an outlier that's in one of my risk-based contracts. Even more, who is asking about these risk factors? It is sometimes our specialty partners, sometimes other care team members, but it is regularly part of the primary care conversation for us. And I think that is where our panel is going to chat a bit about these levers and where we see the opportunity to lean in. We also know the workforce environment with COVID is challenging. I work in a healthcare system, and we're seeing inflationary costs hit us hard, whether it's around making sure we have the workforce we need, addressing burnout and challenges there, or mental health that is impacting not only our workforce, but also our patients and communities. I see in the health system where we also want to start earlier and earlier in life. We know that addressing food insecurity and some of these challenges around broadband access are not issues we can tackle alone. It is the connections between agencies and government that make a difference. We want to ask and connect to these services. We want to invest and take dollars and put them into the hands of those in the community who know where they can make the biggest impact. I also have to start my opening comments with what I saw as a huge lever as Secretary of Health and Social Services with Medicaid. States have inordinate opportunity to think about their Medicaid program, and even more, how Medicaid can play a role in closing health inequities. It is a place to invest and close gaps. It is a place where Medicaid can actually embed measures to incentivize systems and providers to close gaps. And it is also a place to go upstream. Medicaid pays for nearly half of all births and nearly half of the nation's children under age 3. It disproportionately covers people of color. And we know that as of 2020, Medicaid covers 3 in all Black, Indian American, Alaskan Native, and other non-elderly adults. But it is only compared to about 17% of white counterparts. So with the opportunity that states have, and with more and more people seeing Medicaid as something that should cover those time periods in life where we can make the biggest investment, it is very clear that we can lean into this. And I think that our role as primary care is to shape how that is done and to make sure that it is informed by what we're seeing through documentation needs and contracting challenges, but also where the community voice makes a difference. So stakeholders are important. I think no matter where I've been, whether it's on the research side, whether it's thinking about the policy levers, or whether it's running primary care at Nemours, we know that we need to lean in and really bring in stakeholders across the spectrum. Some of that's through value-based payment arrangements, and some of it is through making these connections between social determinants of health and navigation. So I'm looking forward to work where we support primary care, we lift up the opportunity to integrate health equity into more of what we're doing, and then build this infrastructure that's needed, because you do need the data analytics and tools and new team models to figure out how to do this. So we're going to have a conversation about this today. I'm very pleased to introduce Dr. Dora Hughes up to the stage with me to chat. Dr. Hughes is Chief Medical Officer at the CMS Innovation Center at the Center for Medicare and Medicaid Services. She leads the center's work on health equity, provides clinical input on models, liaises with stakeholder groups, and directs the CMMI clinician community. She's had numerous roles, but across academics as Associate Research Professor of Health Policy and Management at George Washington University, where she lifted up some of these same issues. As an internist, she has also held key health policy roles and served the Senate Health Committee with Senator Kennedy and served as health policy advisor to Senator Obama. Thank you so much for joining us today in this conversation, both in person and virtually, and would love to just hear your thoughts on how CMMI can influence this conversation.
Yeah, so I want to start by thanking you for inviting me to join the panel today. I also have to note that you omitted one critical factor from my bio in the introduction, and the fact that I actually trained as a primary care physician through the primary care track in internal medicine at the Brigham. So I think that's, I normally don't point that out, but for this panel today, I have to emphasize that point. I think for the CMS Innovation Center, for those that aren't familiar, we were created as part of the Affordable Care Act in 2010. We were charged to help to transform our nation's healthcare system with focus on improving quality and reducing costs, some combination of the two. And we have sponsored a number of models, more than 50 models since our inception, that have focused on different diseases and health conditions such as diabetes or end-stage renal disease, certain provider types, primary care, of course, also certain specialists, certain settings, communities, such as our rural focus models, specific care episodes. For example, if you needed a hip replacement or knee replacement, that's been another focus. And we look broadly across traditional or original Medicare, depending on how you describe it, as well as Medicare Part D plans, Medicare Advantage, increasingly working with our partners and the Medicaid Center as well. So we have a fairly broad charge and a broad scope that we have focused on extensively over 10 years. But at the end of the 10 years, as part of our anniversary, it made sense to take a look back and think about what are the lessons learned. And I think, to quote one of my colleagues, we had to look back to chart our course forward. And we have released a new vision statement that is a health system that achieves equitable outcomes through high quality, affordable, and accessible person-centered care. And as part of developing this new vision, we, in October of last year, released a strategy document that outlined 5 pillars for our focus. The first is accountable care. We want the vast majority of our Medicaid beneficiaries and 100% of our Medicare beneficiaries to be in relationships, accountable relationships defined by quality and costs. We are focusing extensively on equity, which I'll do a deep dive in a minute. We are focused on transformation, innovation. What types of tools, data, technology can we provide that will help providers engage in healthcare system transformation? We are focused on affordability. And at the broadest levels, how do we address affordability at the health system level, but also at the beneficiary level? What changes can we make that will impact our beneficiaries' wallet or purse, as the case may be? And the fifth area, critically important, is partnership. We've been quite fortunate to have an amazing network of partners that have really helped and championed us all along the way. We want to build upon this network, bring in those that are newer to value-based care, that may represent certain patient advocacy groups or provider groups that haven't typically engaged, and we think that it's critically important to bring their voice into and help us over the next 10 years as we work to achieve these goals. And so just to tell you a little bit more about equity, with this administration and with this administrator, equity, of course, is a top priority for us. And it is one of our 5 strategic pillars at the CMS Innovation Center. You will hear us talk about equity extensively throughout all of our different models and initiatives underway. But within that advanced equity pillar, we are focusing on 4 areas in particular. The first is thinking about how do we embed equity throughout model development? I mean, what models are we taking? What relevance does it have? What are the care interventions, care delivery requirements? What are the payment adjustments and the financial considerations? All of that we want to think about every step along the way in developing our models. And the second area is thinking about how do we increase the number of underserved beneficiaries being served throughout our models. And as part of our core strategy for that is how do we increase the number of safety net providers, Medicaid providers, those providers in federally qualified health centers. How do we increase those groups in our models? And what considerations, what do we need to be mindful for to recruit and retain and enable their success? The third area is evaluation. Always a little bit kind of a humdrum area of focus, but what we did realize in our first 10 years is we weren't always asking the right questions up front, so therefore we weren't collecting the right data, so that often for many of our models, we can't really say with certainty what the impact has been on health equity. And so that's just a critical area of focus, and one certainly that we are elevating in importance. And then the fourth area is really focusing on strengthening data collection and intersectional analyses across the whole range of socio-demographic groups. We are increasingly focusing on the data that we have. At CMS right now, we're certainly thinking about what proxies we should use, how do we impute data, all of that. So we're focusing on the here and the now. But we're also looking forward, and as part of our new models especially, what requirements and supports can we include so that providers will be better equipped and able to collect socio-demographic data that will really help to enhance our monitoring of models and our evaluation of models so that at the end of the model life, we will have a much better understanding of what the impact of that model has been across the whole range of beneficiary groups, which is just really critically important when we think about generalizability, especially. So those 4 areas is kind of certainly guiding our work on equity, and I think has relevance for much of what we've heard earlier today, especially as part of the last panel, and it certainly is very exciting for us moving forward.
I think that's great, and it is great to be joined by another primary care doc on the panel. I think we are very proud badge wearers today, along with talking about some wonky data, nerdy kind of things too. Do you want to talk a little bit about how we think about leveraging prior lessons around primary care? Some of the prior models at CMMI certainly have those lessons, but it sounds like you're really thinking about how to build upon that and expand. And some in the room and on the screen may have actually even tried out some of those models and had their own thoughts to share.
Certainly, so I can share my view, but then certainly welcome to hear others' perspectives. I think even in the earliest days of the CMS Innovation Center, we've acknowledged just the critical importance of primary care as the foundation for a robust and effective health system. We have had 3 models to date focused on primary care, the Comprehensive Primary Care, CPC, Comprehensive Primary Care Plus, CPC Plus. And just in 2021, we launched our 3rd primary care model, Primary Care First, or PCF. And we're excited. It has almost 3,000 practices participating in 26 different regions. And it's really throughout all 3 of our models, we're continuing to build upon our lessons learned, successes, experiences. And what we found, and I'll speak to this briefly because I know our director will focus even more on this as part of the next panel. But what we did learn from CPC, CPC Plus was that primary care practices, they are able to transition to hybrid payments of fee-for-service, capitated population-based payments. They were able to make that transition. We were able to see some of the practice changes that we had hoped for, whether that's improved care coordination, if it's targeted case management. We were able to see more behavioral health integration, just a lot of changes that did translate into what positive directions in health outcomes in terms of healthcare utilization, also improvements in some of the clinical quality measures. And that was particularly true for practices that participated in CPC and then continued on in CPC Plus. Primary Care First continues to build upon all of the earlier models with, for PCF, certainly being focused probably more on practices that are more experienced in taking on value-based care interventions and arrangements. In this model, there is a downside risk. So it is comprised, of course, of practices that are able to assume such risk. But you did also ask, and so that's kind of charting in brief our engagement in primary care, but you did ask about lessons learned. And so within the equity context specifically, I would say some of the issues that we are thinking about now is if you look at a heat map of where the primary care sites have been situated, they have disproportionately appeared to be more likely to be in areas that are less diverse, less underserved, higher income. And that's true, even surprisingly, when you look at areas such as Detroit. And I was just amazed that you could still have a fairly fewer underserved practices, populations being served, less diverse populations in Detroit and Los Angeles. And so really, we're not serving the full range of beneficiaries in our Medicare and Medicaid programs if we're not including particularly the range of populations and underserved populations tend also to be, in some cases, higher income areas. And as part of that, we also know that we don't have as many safety net providers participating in our primary care models too, and the two certainly are related. And so those are examples of two considerations within the equity context. We want to make sure we are providing equitable access to our models, that we're seeing the full range of beneficiaries in our models. And then back to our original point, because equity was not always part of the evaluation, again, we don't actually know in many cases what, with any, in a reliable kind of way, like what the impact has been. So those are some of the lessons that we certainly have taken to heart and starting to think about now. Certainly, we have not shied away from the fact that we are already thinking about what's to come in primary care. We have Primary Care First that just launched, but already starting to think ahead. How can we address some of these challenges that we're seeing here? What would it take to really focus on equity? And I really think that if you think about our pillars, that it helps to provide a roadmap in some ways. Again, if we think about first, model development, what's the care delivery interventions? How are we ensuring, for example, that we're providing culturally and linguistically appropriate services as one example? I think what you said, just as part of the introduction, critically important. How are we ensuring that we're including screening and navigation, referral to services as part of the model? Actually, can we even move more upstream and try to take on, forge the relationships that will allow us to address social determinants of health at the community level, in addition to thinking about our individual needs? And so, so that's one focus. The second, how can we make sure that we have a diverse beneficiary base in our models? And paired, but correlated, but not exactly the same. How can we increase the safety net providers that are participating in our models? And so that's a second area of focus. Evaluation, what is the design? How are we asking the questions up front? And what is the data collection requirements that, that need to be in place so that at the end of the next period of time, and note, I say the period of time deliberately, another lesson that we learned is we didn't always capture, we think, the full outcomes in a 5-year period. So do we need to think about a longer lifespan, particularly if we're thinking about social needs and screening, addressing some of those issues? It could take a longer period of time before we're able to fully capture the improvements in quality and costs. And so that's where we're certainly being very thoughtful. And then the final thing I would say, a very long answer to your one question, in terms of partnerships, we understand if we're thinking about these issues that, first of all, we need to work more closely with a number of external groups who, again, represent those that may not have typically always participated in our models. I would say the National Association of Community Health Centers, NAC, would be one example in terms of we need to hear. But even also thinking even outside of CMS, like who are the other agency partners that can be helpful? How can we tap into the expertise of ACL and their area agencies on aging as an example? How can we tap into CDC and their expertise on SDOH? And certainly, I mean, there's no point in trying to say we want to focus more on FQACs if we're not communicating and talking and learning from HRSA. And that's what they do. And so all of that, there's just a whole series of conversations on top of conversations. And really, I think, will lead to, I think, meaningful steps forward in terms of equity and in the primary care context in the months ahead.
Very exciting to hear those lessons and think about the models in the future. In some ways, leaning into the investment and the opportunity is informed by past lessons. But if you don't know where inequities have closed through these models or where the investments mattered most, it is a little challenging. I wonder if you want to share a little bit about where you think you could lean in for new ways for primary care to create those opportunities and close gaps.
And I think I would point to ACO REACH, which is not quite, that's definitely not apples and apples comparison, but some of I think it helps to illustrate some of the concrete steps that we've taken, and without making news today, because always trying to remind myself what's public, what's not public. But ACO REACH, which we released in March, had 5 equity provisions that I think provide a nice example. One such example is requiring all the participants to develop health equity plans. That sends a clear signal that we expect our participants to know the populations that they're serving, to collect the data so that they can identify disparities, to share with us what interventions they think will help to close gaps in care and outcomes, to evaluate on the back end, and also that it should not be static. You should be able to update over time as your population should change or your services expand, whatever the case may be. So I think having the health equity plans is, and there was also a health equity plan requirement or option as part of our VBID model that was released earlier as well. So I think, again, asking your participants to take more deliberate steps to share with us what you intend to do. And I think that's one way. The other, and I also think our accountable health communities model, which is just coming to an end, is in many ways our flagship model on health equity in terms of trying to link health, public health, social service partners to allow not only just screening, but also referral for beneficiaries who have social service needs. That is something else that we're building upon. We're hoping to embed in our ACO, but certainly increasingly in our primary care models, being really thinking about not only how can we screen and refer, but how actually are we bringing in the community partners into the care teams in primary care? How can we support community health workers and others, particularly those with lived experiences from the communities that we're serving? How can we actually bring them into and support and reimburse and all of that? That's where we're trying to think about how we can do that, particularly in primary care models moving forward. What would be the possibilities? What type of flexibilities may we need to embed? So I think those are 2 examples that I'd like to mention.
Thank you so much, Dora. I really appreciate it. So I'm going to expand our panel up here and invite up Dr. Roger Montgomery, who currently serves as Executive Medical Director for the Cherokee Nation under the leadership of Chief Chuck Hoskin. The Cherokee Nation health system is a comprehensive health system that consists of a 60-bed inpatient hospital, 9 outpatient facilities, adolescent treatment center, and much more, including behavioral health and community and prevention services. The Cherokee Nation's health system is the largest tribally operated healthcare system in the United States with over 1 million patient visits. It is truly a pleasure to have you with us. Another primary care physician, internist, must introduce you that way, but also to make sure that you're doing work that really ensures high quality services that are culturally appropriate. And I really appreciate you joining us here. We're going to hear a little bit about what you're doing on the ground to implement key strategies and work day to day to overcome inequities. Would you like to share just a few thoughts about what you're doing?
First
Orient
of all,
the group. Thank you.
It's good to see you all. And again, thank you for inviting me. I like to start by just sharing the story of, very brief story of the healthcare for Indian people, and particularly for the Cherokee Nation. As you mentioned, we're the largest tribe. We have over 400,000 registered tribal members. Our tribal boundaries, our tribal reservation extends over 14 counties in northeastern Oklahoma. If you think of the state of Oklahoma, think of that upper right-hand corner. That's our tribal reservation and where our tribal citizens live. And we refer to ourselves as citizens because we are a sovereign nation. We have a unique relationship with the United States government that renders our tribe as a sovereign nation. And we acknowledge that by saying we are tribal citizens of the Cherokee Nation. Historically, the health disparity that is important to emphasize for Indian people and Cherokee Nation in particular is the fundamental lack of access to quality health care. It has to do with the number of facilities, number of providers, the scope of services offered through traditional health care services. And that played out with the Cherokee Nation. There was one facility for years that served those whole 14 counties. And it was just a traditional type of healthcare facility, inpatient beds, primary care, pediatrics. At that time, it was internal medicine, pediatrics, general surgery, obstetrics, and gynecology. In 1984, the Indian Health Service built a larger facility there in Tahlequah, again, the tribal headquarters, but still a single facility serving all 14 counties and all tribal citizens. In 1988, that's where I first went to work when I finished my primary care training in Boston City Hospital. I'd like to acknowledge my mentor, John Noble. He was one of the pioneers of primary care and wrote one of the first primary care medicine textbooks, died last year in October. But again, that was the place I first worked, and I thought it was a wonderful facility, thought it met all of our needs. But the demands, the need for services has steadily grown over the years. In the early 1990s, the tribal administration recognized that one facility did not meet the needs of the tribal citizens and was leading to health disparities. How do you best fix that? You build more clinics and you strategically locate them across those 14 counties with the goal that no tribal citizen will have to drive more than 30 minutes to receive medical care. And over the years, the tribe has accomplished that goal. There are now 9 outpatient health facilities strategically located across those 14 counties. They've been remodeled, they've been upgraded, they've been added on to, some have even been replaced. But those 9 facilities still exist. Some, quite a few of them, are over 100,000 square feet in size. We've done an enormous, tremendous job addressing the problem of just the geographic location of healthcare and patients and tribal citizens' access to those facilities. Second problem, are there enough providers? Historically, no, there have not been, and we still struggle with that. It's an enormous challenge, but in the last few years, I want to really highlight some success that we've had. We live in, Cherokee Nation is in the state of Oklahoma. Oklahoma State University School of Medicine several years ago recognized they needed to meet the demands of the needs for increased providers. Oklahoma ranks only above Mississippi and Idaho in per capita physicians in the United States, well below DC, which is I think around 790 per capita. Oklahoma is around 200 per capita physicians per 100,000. Oklahoma State recognized that need and reached out. They wanted to find a good partner that would support them in their efforts to train physicians to work in the rural setting. We reached an agreement with OSU, and in September of 2020, the first class of 54 students matriculated at the branch campus there in Tahlequah on the campus of Cherokee Nation. Due to supply issues, the school had to delay its opening a few months, but in January, the doors of an 85,000 square foot facility opened there in Tahlequah, the branch campus for Oklahoma State University School of Medicine. That's a long-term, sustainable solution to providing, to realizing the need and addressing the need of providers within the state of Oklahoma. The other thing that happened in the last year or two is that we inherited a family medicine program from the local for-profit hospital. And recently, we're very, very thankful to receive HRSA funding that will sustain our program in the coming years. We were approved for 8 slots, and this last month, we graduated 3 of our senior residents, and very proud of that. One of them came to work for Cherokee Nation. Again, a sustainable solution to addressing the need for providers in the health system. And I might add, OSU, their focus is rural medicine, and they even have a tribal health track. They recognize they need to train those physicians to be aware of and be able to culturally relate to those patients that they might encounter in a tribal setting. Very proud of that. So we've addressed, I think we have long-term sustainable solutions to address the shortage of providers. The other thing I'd mention is Cherokee Nation, of the 330 providers that we have, 40% are Cherokee. 40% are Cherokee. I'm very proud of that. We have the facilities now. We have a solution to continue to supply or grow the number of providers that will address our increasing need. And we are hiring physicians that will stay in those communities and work there long term. That is an important solution to addressing health disparities. And again, I just wanted to highlight that story. I hope sharing that is helpful to you. But that is one of the things that several things we've accomplished over the years and more recently.
I think that's so important to make sure that you have the workforce to address the needs, but also those who are reflective of the community, and know who to turn to. I wonder if there are opportunities that you've really seen through the pandemic, whether it's early on, later, now even into recovery, hopefully, to build necessary investments and infrastructure to address some of the quality and also the ongoing needs.
Well, the earlier panelists, what great comments. Very enlightening to hear some of the things that other health systems have accomplished. What an enormous challenge, and for all people across the world to address something that was evolving at such a rapid pace that we were all just scrambling on our feet. Hearing some of the things that we've embedded those IT solutions that we've all talked about that help with reporting results, contact tracing, those are now embedded in our healthcare system and will be a solution for other problems that we encounter along the way. Telemedicine. We stumbled with that, but we finally found a platform that worked, that made it was easy to use for our patients, but we still struggle with broadband access. And when people can't afford a phone, or they have it for a month, change their phone number in a month, telemedicine isn't very valuable to them. So we struggle with that, and we're looking for solutions for that, but that continues to be a serious, serious problem. The one thing I'd highlight about the pandemic that I think was unique to Cherokee Nation, culture is language. And to the Cherokee people, first speakers are our past and our future. And we recognized early on that to preserve our culture, we had to identify those first speakers and be sure that they were vaccinated. And to accomplish that required leadership. And Chuck Hoskins, our chief, our tribal council, they didn't let politics get in the way. They listened to science, they listened to our experts, our infectious disease expert, our public health expert, and allowed us, with their support, to reach out to our first speakers and offer them vaccination and health for the future. And we were very successful. I can't quote the exact numbers, but that was a focused effort where we had actually focused teams that would go out into the communities to find these people that were willing to be vaccinated, but with the support of tribal leadership.
And I wonder if you could talk a little bit about the dynamic between getting the investments that were coming from all sorts of places during the pandemic and getting engagement from community members to guide where to focus and where to prioritize.
Well, you're right. Within our health system, we were very thankful for the various investments, and I have to acknowledge we were very fortunate to have a partnership with the Indian Health Service. They had a pathway to provide testing and to provide vaccines and also the evolving treatments that were available during the pandemic. We were very, very fortunate to offer those. But I was surprised, Dr. Walker, again, we have, I think, effective means of communication, social network, published paper communication, and then word of mouth. That's what probably was the most successful, but it took the leadership of our tribal leaders supporting that to make those communications effective and engage the communities in doing what was best for the health of our communities. I hope that answered your question.
Absolutely. I think, from our perspective at Nemours, we saw that having those community voices was so incredibly important to get just the word out about opportunities to engage and really for our underserved and minority communities. We needed people trusted from the community. It sounds like you had some similar experiences.
And I would add too, and because this is a conference about primary care, there were those that had no difficulty making the decision. But those that struggled, who do they look to for advice? They look to that trusted person that's been caring for them, caring for their families in their communities. And as you said earlier, the people that look like them, that talk like them, that come from their communities. Those are the people you end up reaching out to when you're not sure. With years of historical mistrust of the federal government, getting our tribal citizens to be vaccinated was just a huge challenge. But those that I think our primary care providers were very effective in using their leverage to successfully get people to be vaccinated.
I wonder if there are other examples that stand out to you around where primary care can play a role in reducing inequities. I mean, we're all here thinking about primary care and its role and importance. And we do have that trust, we have that relationship, but I wonder if there are other examples that you've had, whether it's in chronic disease or prevention or other gaps that you've been maybe frustrated but tried to tackle along the way.
Well, I think most of the American public knows that the burden of diabetes on American Indians has always been higher than the rest of the population. It's been an enormous problem. We've been fortunate, though. For several years now, we've received unique funding, the Special Diabetes Program for Indians, SDPI. It's provided substantial funding that goes into the oversight of the care of our patients with diabetes. Once a patient is identified as having diabetes, they're entered into the diabetic registry, and they're followed by our staff. And in those traditional metrics that we all know about in medicine, we use those, and we use them effectively. Hemoglobin A1C control, blood pressure control, counseling on smoking cessation. That data is collected routinely and distributed to our medical directors and is shared with our providers on a monthly basis. And it's been a very effective tool. Yes, diabetes is still, the prevalence is still higher than the general population, but we've seen our numbers flatten, and we hope that in the future we'll see those numbers decline. And again, we're very fortunate for that funding, but it is embedded now within our providers to look at those numbers and try to find solutions as they arise to address the care of patients with diabetes. The other important thing I want to mention is that we have a very unique tribal health assessment. I'm very proud of this. We have a FAB-accredited public health department comprised of a variety of epidemiologists. And the second tribal health assessment is going to be coming out in the next month. Within that is a wealth of information on colon cancer rates, age-adjusted mortality by diagnoses, suicide rates, prescription of opioids across the counties within Cherokee Nation, socioeconomic information collected by Cherokee employees, Cherokee citizens, data that we're very possessive of, unique to our tribe, that we will then translate to our administrators to help make decisions on where to focus, because this data highlights those disparities. A higher than average lung cancer rate, higher than average colon cancer rates, higher suicide rates among certain age groups. We're going to use that data to focus our efforts, is the right word intelligently or just the right way? Maybe that's the best way to say it. We're going to use that information to improve the health of our people. It also has survey data from tribal citizens, over 700 of them, asking them, what's important to you? What's important to your community's health? And not surprisingly, mental health is at the top of the list. Substance use disorders at the top of the list. And it's going to guide our decisions, guide our policies, not only within health, but within the tribal administration, and it'll be very, very valuable information. So I hope that's a helpful illustration of what we're trying to accomplish and how we're going about it.
I think it leads to another great conversation that we can think about in terms of the importance of measurement and the importance of quality and quality tools. You know, in some ways, what we're all trying to do is understand where those gaps are and where we can create a plan and a strategy around it. I know at Nemours, we are trying to we aspire to break down all of our quality measures by race, ethnicity, and language data. Now, I would say that work is hard because it starts with having high quality race, ethnicity, and language data, which is tricky in real world settings for many reasons. We're working on it hard, but there's a whole framework behind doing that well and then putting it into the hands of those providers who are actually seeing that patient in the context of dashboards. But in health systems, I don't know if in your world, but what is measured gets done. What is measured and provided as feedback to our teams actually creates next steps and plans and care coordination, care management efforts. And so I wonder if that's a conversation we can all have about how we use a quality framing and quality tools in the primary care setting to drive plans around closing health inequities. Dora, I don't know if you have thoughts about that.
Sure, and this is another really important area of focus for us. We have a team we call the Quality Vertical, or the QV, that is very much focusing on helping us think through what is our equity quality strategy. And by that, there are just general, to your point, how are we stratifying the outcomes that we have? And by certain demographic groups, we are certainly looking at very closely following the standards, the voluntary standards by ONC, the U.S. Core Data Interoperability version 2, version 3, CDI version 2 and 3, which to your point has race, ethnicity, language, but also, and especially in version 3, we'll have even more the social determinants as well. And so we think that if we can peg ourselves to existing standards across, for our internal work, across our models, that we will have a uniform approach to assessing the quality. But I also think it's very important that we are trying not to have a lot of sunlight between us in terms of what we're doing at the CMS Innovation Center, what the Center for Clinical Standards and Quality might do, what our colleagues in the Center for Medicare, CMCS, we are regularly meeting across the centers to hear about what is your equity quality strategy? What are you collecting? How will you stratify? We've had some pretty robust discussions. That's always code word for disagreements in terms of the approach, or even thinking through, should we use, in terms of geographic indices, is it ADI versus SPI, or what's perhaps the ARC index? I mean, just really thinking through. We think that if, to the extent that we can harmonize this better on the back end, certainly as we do the quality assessments, but also hopefully will help to minimize the burden on our providers who are collecting the data with that. And even in an ideal world, starting to being very mindful, is this something we can work with other payers in terms of also understanding their quality strategy. The only other thing too is that in addition to the specifics, measures, CMS Office of Minority Health, with leadership by Dr. McKeever, has developed the HES, or it's a combination, a composite measure, if you will, the Health Equity Summary Score, I believe. And so also being thoughtful that the HES is not applicable to every situation, certainly, but are there other composite measures that it would make sense for us to think about, to innovate? Is another, and then the final thing, and then I really will be quiet, is that we are also increasingly focusing on patient-reported outcomes. How can we focus more on the patient experience, What are the problems that already exist that we might want to adopt? Are there, again, because we are the Innovation Center, are there ways that we might want to tweak some of these measures that we could test out in some of our newer models? So it's a very robust area of work, and I think just so critically needed, particularly as we move forward in the primary care space.
Greatly appreciate that leadership. I think thinking about how to make sure that the incentives around the payment arrangement to make sure that we're not discouraging participation by very complex and socially complex patients is so important, because it is really hard to get providers on board when you're trying to say, yes, I also want you to take care of the most challenging of our patient panel and manage to cost and outcomes. Dr. Montgomery, I don't know if you also want to share any thoughts about quality measures in the context of trying to increase access and really, think about diabetes and mental health and some of the challenges that you're tackling in terms of how to make sure we're really doing that in a culturally tailored way.
That's a good question.
You can say skip or pass, or someone in the audience might have an answer.
I think, again, just communication from the top down to our providers, what the priorities are, what's important to the overall health of the community, making them providers realize that their jobs are not just within the four walls where they work, that they're having an impact outside of that clinic space. Providing that information, as I said before, we're going to be sharing with them that information that should impact their decision-making, that in turn will lead to improved quality of care. I hope that makes sense, but that's how I would answer that.
Absolutely. I think there's another aspect to thinking about partnership and thinking about the stakeholders who need to come together around health inequities. It can't just be the healthcare system or just the federal or state agencies who support some of this work around social needs. But I wonder if we want to have a little conversation around the role of the private sector and how they can facilitate some of this work. And I think in some ways, those who are in the private sector can come and play an important role. We've seen it at Nemours in terms of investing in innovation, in ideas that otherwise don't fit into our current model. For example, creating a medical legal partnership, where right now that lies far away from the normal payment, fee-for-service, or even value-based payment. But in the future, we want to test out what works among which patients so that we can deploy that. But right now, it's funded through philanthropic funds and partners who are coming to the table saying, this is important. Another example is where we're really leaning in with large employers in our community and working with the Chamber of Commerce to think about where health happens in the workplace. Now, we take care of kids, but families are seeking ways to navigate, and often things like telehealth are a place where we can build out ideas and partnerships, or creating kiosks that are in communities can be funded through those partnerships to make it more convenient for parents to get healthcare navigation in a setting that's convenient and beyond our walls. I don't know if there are other ways that you think maybe the private sector can come in and help us address some of those health inequities and challenges. Dr. Hughes, if you want to start?
I'm happy to start. I think we are increasingly focused on multi-payer alignment at the CMS Innovation Center for a number of our models. For all the reasons you mentioned, when we think about our models, for example, we know if we are focusing on FQHCs as an example, but perhaps only 10% of their beneficiaries are Medicare beneficiaries. And so how do you encourage a practice to make a number of certain changes if it's really only going to benefit 10% of their beneficiaries, 10% of their payer base? I mean, what's the incentive? But if you're able to align across payers, and so perhaps you have FQHC is not the best example, but if we think about primary care practices more generally, if you have some of the commercial payers and Medicare and Medicaid all in lockstep, and so then you're getting a much higher number of patients who are being funded by across all these various sources. And then in that case, it does make sense for a practice to say, okay, well, maybe we should adopt this change, or maybe this practice makes sense for us. And it's not even just payment, but even on quality measures, if we align across, if we're and the federal government, if we're aligned with what private payers are requiring, what states may be requiring, it just makes it that much easier, much more likely that a primary care practice is going to take that on. So we think that the private sector, in terms of multi-payer alignment, is just really critical. I would also have to say, just in terms of the private sector, we are also very much attuned to what's happening in terms of what the types of data they're providing, what is the technology, what are the tools, what are the supports, in terms of both how does that inform what we should be doing, but also what are some of the gaps that we need to wrap around and saying and thinking through, this is not being addressed by anyone, and this is a logical place for the federal government to join in. So I think it's kind of that whole push-pull, both in terms of learning from the private sector, but also helping, what is our role in terms of informing or helping to address some of the remaining needs. And so I just think the general partnerships, multi-payer alignment is just critically important.
Roger, I don't know if you have thoughts about the private sector and their role or the opportunity you see for the future.
That's a good question again, and because we are a rural-based health system, and the private sector, typically the largest employer in some of these communities is Cherokee Nation. It's a little harder to align with what I hear about in terms.
Or he doesn't need to align, is what he's saying.
That's yes. So but I think we're open to. I think we want to be open to what other solutions arise from the private sector for sure.
Yeah, I think that the stakeholder alignment is helpful, and sometimes helpful to know where to stay away and where to lean in, maybe in some ways too. I hope there are questions in the audience. I'll ask one more and then see if there are any hands. But I think the other question is the role of social determinants, social factors, social needs, whatever your favorite term is. I think that the question is, how much of this should we embrace and embed in primary care to move to better value and greater equity? And how much do we think it needs to be kind of a partnered role? And I will, take moderator's prerogative and just say that, I think it's the biggest challenge we have. We know how important they are to driving better health. Yet we don't have the resources to necessarily navigate and build all of the housing that's needed. And so finding ways to both navigate and provide and maybe even train our future workforce to know where those assets are. We have some uber social care navigators that are just really good at their community. They're from the community. They know who to call. They pick up the phone. They know the name. They know the phone number. But I can't institutionalize that knowledge and that ability to navigate. It takes time and effort. And so I wonder if there are other things or lessons that we're learning about social determinants that we should share with our audience for future thinking.
So I would say for us, screening and referral, helping to navigate to address social needs, it's almost like beyond a question at this point and just something that we're trying to figure out, how can we do this? We're at the implementation stage. And it's certainly increasingly expectation. It will continue to be expectation across our models, particularly our new models, in terms of, again, how are we understanding the needs of the beneficiaries, the people that you're serving, how are you helping to address? And in some cases, could it be for some primary care practices that particularly the larger, more resource in certain areas, that this is an area that they can do more themselves? In other cases, perhaps it makes more sense for the primary care practice to partner with others in the community who can better serve that role. And so whether it's done directly or through partnership, we think it's critically important for it to happen. I do want to say, again, I mentioned earlier, we're increasingly partnering, thinking through how can we partner with some of the other agencies. Administration for Community Living is one example, or HRSA. So I think in some cases, other agencies have been doing it longer. They've been focusing on these issues. They can do it better, and certainly it makes sense for us to partner. Sometimes it's important to stay in your lane. Other times you want to veer back and forth a bit. And so we're still trying to figure out what is the right space for us at CMS to help push this area forward. But we do think that setting the expectation, setting the tone, embedding it in our models moving forward, just making a thing is what we're doing. And we're not just even when we have these requirements, and we're also trying to help. As one example, in our data shop, they created a FHIR-based questionnaire that can help facilitate the screening and the collection of this information by providers. We're also thinking about how are ways that if we're asking you to share this information, what are some of the mechanisms there are some that will be quite sophisticated. They can have it extracted from the EHRs and send it in. Okay, that's one, but we also have others that we're quite mindful that basically they're going to dump the data on us through Excel files or whatever. And we want the information, we'll take it any way that we can get it. And so we're trying to think ahead, like what are the various mechanisms that need to be in place? So what are some of the considerations on the provider side as well as on our side to collect and receive? And how can we make sure we'll be better prepared? We're starting to pilot some approaches now, and we're hoping in 2023 that we'll be in a position to help collect some of this information. But the final thing I would say, when we think about certainly in health equity, we can never forget about the racial equity component of health equity. And so screening, referring a referral, addressing social needs is critically important, but there are other steps that we need to, but it's not only, and we have to be careful not to conflate screening for SDOH and social needs and as thinking, okay, we've checked the box and we're done with health equity. I think tomorrow's panel on maternity health certainly is a classic example of even for those, in this case, those moms that are the highest educated, the highest income will still have disproportionately poorer health outcomes. And so it's critically important to address social determinants, but insufficient to do that only when we're thinking about what do we need to do to achieve health equity.
Any thoughts, Roger, about that?
As I mentioned before, we'll be releasing a tribal health assessment in this month. Also contained in that is information about the availability of healthy food, healthy eating habits. Questions in those surveys about concerns about domestic violence, covering all of those issues that are outside of the provider's office. That information will be there. It'll be a wealth of information. One of the earlier panelists I thought was just remarkable to hear about the thought of having medical students do case work looking at social determinants. What a great idea. But within our health system, I already know, we do have, as I said, we strive to have a behavioral health personnel in all of our clinics, licensed clinical social worker. Those people should hopefully have that information that tells them how they can help those patients with those issues as they arise at that moment when they're in the clinic. And I think we do that already. We can always improve on that, but we are going to be sharing this information across our tribal system. We have an education department. We have a housing department. We have a variety of services that not all of our tribal citizens are aware of that we could better coordinate through our community health centers. That's, I think, a challenge for us, and I think we can always improve on that.
Yes, lots of opportunity. Are there questions?
My name is Jonathan Bushman. I'm a primary care physician in Oklahoma. Thank you, Dr. Montgomery, for not allowing me to be the only Oklahoman in the room. So as an OSU graduate, I am extremely proud. Also president of the Osteopathic Association in our state. We're super proud of our partnership that we have with OSU and Cherokee Nation and what you guys are doing. So thank you for your influence and being here today. Dr. Hughes, my question, I actually left a CPC Plus model 3.5 years ago and launched an independent practice in a value-based direct primary care model. And part of my reason for that was the misaligned incentives within the exam room. And the misaligned incentives didn't have to do with the CPC Plus model, it had to do with the way I was paid. So I know we kind of, even in Dr. Blumenthal's discussion about pay increase or compensation change, it's really hard to have that discussion with our legislators and people, policymakers, trying to push on that because it sounds like we're all about the money. But I would say it's not so much the compensation, it's the incentives being aligned. And Oklahoma just passed a bill last week. I say passed, it's on the governor's desk for Medicaid expansion. We're one of the last states to finally come to the table for that. And one of the things that we as an association in primary care, we were concerned about is this very issue, that the ACO models that may get awarded these contracts, we're a little fearful that while at the health system level, those payments will be made on an incentive for quality or value, we're concerned that our employed members of our profession may not see the actual incentives within the exam room. I'm kind of curious from CMS's perspective, how can you legislate that? How can you keep the middle people in that discussion accountable for paying the clinicians for the same incentives that you've created at the top level?
So I won't comment on how you could legislate as a federal official, but I think you raised such a critically important point, and one that as part of our 10-year look back and lessons learned. One of the lessons is we had so many models, some would say too many models, that occasionally you had to figure out what's the dynamic if you have ACO, then you have a bundled payment, perhaps you have an AHC, it's state total cost of care. I mean, so you have these different incentives in different parts of the healthcare system that could be in conflict. And at the end of the day, to your point, perhaps the resources, the flexibilities are not being appreciated or realized by those that are actually in the exam room who would benefit in some cases most directly from the enhanced resources. And so that is an issue that we are certainly trying to think about. It's not even just the mechanism of the payments or whether it's the straight adjustments or the benchmark, not even just that, but also just thinking about how do these various models, how can they work better together so that it's more synergistic. And also, I think you also raise a point too. It's not always just the payment, but it's also in some of the population-based payments, the capitation models. I mean, it's the flexibility to use the funding in ways that make the most sense for your practice and for your patients, and whether it's hiring a different provider type or if it's having the funding for a community health worker or a licensed social worker, whatever the case may be, that it's the payment plus the flexibilities together that in many cases we think can make the difference.
And I'll just add, from my work at the state level, there were a lot of models that exist across the nation to figure out ways to invest more in primary care. But some of it comes down to transparency of what dollar actually flows to primary care. And so, we did it one way in Delaware. I would say it's still evolving, but we were looking at models in Colorado and Oregon and Rhode Island and Connecticut to see how you can use the legislative process and engagement effort to lift up primary care investment. But I will say, now being in a health system, it really depends on how those dollars flow and create investments in value, investments in the care team, and some of that doesn't naturally flow unless you're having that open dialogue. So I think it is the question, and then you layer on health inequities. It really is, how do we make sure we are investing in the right mechanisms and tools for data analytics and quality incentives, and making sure you have the right capacity to build out what is needed to prevent those hospitalizations and avoid those unnecessary costs that really do require kind of a holistic kind of culture change. And some of that is not invested or legislated. It really is just bringing people together. I'm glad you're doing that work. So I think we are out of time and moving on to the next panel, but I want to thank Dr. Hughes, Dr. Montgomery, and everyone here. Thank you so much for joining us for the panel today.
Thank you.